Hey kids, so it's been a while since I was on here. Okay, so we're discussing the basics of histology today, and we are covering breast today. I will be first covering the normal breast histology, and then we'll go to the abnormal breast histology, some important entities that we see on a daily basis. And again, I'm not discussing the normal anatomy here, we are just directly skipping to the histology of breast. So there are two parts in the breast, right? Glandular tissue, which we'll discuss in detail, and then we have a stroma also, okay, which is majority of the breast in which the glands are suspended. Now what is glandular tissue? It is basically breast parenchyma having 15 to 20 lobes are there. Within each lobe there are ducts. Now this is the proper system from the collecting ducts which are arising from the nipple to the Tdlu, which we eventually see from the level of the nipple. They were collecting ducts, they go to the lactiferous sinus, then we have lactiferous duct, then segmental or subsegmental ducts, and then we have the terminal duct, and then we have the lobule, which is your main unit, terminal ductal lobular unit. So there is two types of stroma, that is interlobular stroma within two Tdlus, let's say, within ducts, let's say, and interlobular stroma is within each Tdlu. So interlobular stroma is surrounding the large ducts and Tdlus. It's basically made of dense fibrous tissue or adipose tissue because it is stroma. So these are the it will have the mesenchymal components and elastic fibers. Then we have the interlobular stroma, which surrounds the acini within the Tdlu. It is loose comparatively, and it has scattered inflammatory cells as well as some blood vessels, and this is the stroma which is hormonally responsive, and it does not have any elastic fibers. We are going to the glandular component. We are going to discuss the basics of the glandular component. We know that the ducts or the lobules are lined by two types of cells. We have the epithelial cells and we have the myoepithelial cells. So any organ which has duct system, the glandular system based on ducts, so because it is a gland, anywhere we have a gland we will have duct system, and duct system or lobules have two types of cells, which is epithelial cells and myoepithelial cells. Now epithelial cells we know are the luminal cells, and they are the secretory cells. They are the ones which are secreting something, and because it is breast, so they are producing milk hair. Okay, and these cells can be columnar type or cuboidal type epithelial cells. And then we have the myoepithelial cells, the basement membrane cells. They are abluminal, they are not the luminal, they are the opposite of luminal, and they are contractile. Why they are contractile? Because they assist in the milk ejection during lactation. Okay, starting with the pictorial description of each part of the breast. First is, we know that whenever there is mastectomy specimen, we take a section from the nipple areola complex. So this is a section of the nipple. So this is the surface of the epithelium, right? And then we have a single sebaceous gland, and then L is what is your lactiferous sinuses which are present. Important thing, this is very important. This picture is showing Tdlus, okay, your terminal ductal lobular units. First picture is at low magnification. So you see these branching ducts, right? These are branching further and further and further and further. These are surrounded by this pink colored, relatively dense, I mean it is quite dense, that means it's probably a young female, reproductive age female, and this dense fibrous tissue, and these empty spaces are, we know that that's fat. So that is your breast. So you see that again, this is higher section. Again, you can see from a duct, you can see that from one single duct there is one Tdlu arising, further branching, and then we have the pink color is your stroma, and then we have the fat as well. Now look at this. This picture shows the cells which are lined, which we talked about earlier. Epithelial cells are towards the lumen of the cells. They are luminal cells. They have to secrete stuff. That is why this is the gland we are talking about. And then we also have the basement membrane पे जो supportive cells हैं. We also have the myoepithelial cells. The epithelial cells can be columnar or cuboidal as well. Myoepithelial cells are usually stellate and have pale cytoplasm, and they surround the duct cells. I'm not going to discuss every entity, of course, but I'm going to discuss the most important entities. Fibroadenoma arises in a young female. It is a benign tumor, well demarcated circumscribed tumor, and it has, when you cut it, it usually has a whorled appearance. It can show slit-like spaces as well. The median age of presentation is considered to be 25 years. It is usually younger as well. It can be a little on the higher side as well, up to 30 years. This picture shows your intracanalicular fibroadenoma. Now, fibroadenoma can be intracanalicular or pericanalicular. Whether it is intracanalicular or pericanalicular depends on the relationship of the stroma with the glandular component. So in this, the stroma is invaginating into the glandular component, so that is why this is the intracanalicular pattern. The ducts are completely compressed. They are almost linear branches, right, with slit like lumens only. But when it comes to the pericanalicular pattern, the glands maintain their round or oval profiles. Although there is no prognostic or clinical significance attached to whether it is a pericanalicular or intracanalicular pattern. Tubular adenoma is kind of related to fibroadenoma, but the main thing is it is comparatively seen in a younger age group. It usually is it can be a solitary circumscribed firm mass, but I have seen a case in our department in which a patient had multiple lesions in both the breast, and I am talking 10 to 14 masses in both the breasts, right? So the histology is very different from fibroadenoma. It consists of closely packed small tubules, these round structures, your glands, and they are lined by a layer of epithelial cells and underlying epithelial cells, which is the normal layering. The stroma is very minimal here, okay? That's why it's tubular adenoma. So now there's something called as fibrocystic change. This might be seen grossly as sometimes like cysts scattered in your fibrotic breast tissue. Of course, it occurs from 25 to 40 years of age, and this image you can see variable size of these cystic structures are seen. These empty looking things are your cystic structures, and they're of various sizes and shapes, right? And the importance of fibrocystic changes that usually even clinically, even radiographically or grossly and even microscopically, it can mimic carcinoma. That's why fibrocystic change is important, and can have apocrine epithelium in the center. If you see, whenever we are talking about apocrine epithelium, means that there is abundant eosinophilic granular cytoplasm, prominent nuclei, and apocrine snouts. So apocrine metaplasia has occurred. Even if there is some level of atypia in apocrine changes, it is not a risk factor for carcinoma. Okay. Now, another important entity that you must know is your phyllodes tumor. It can be benign, intermediate, or malignant, and it can, if it is high grade phyllodes, patient usually will have a very short history of rapid growth, and 20 to 30 centimeters in diameter, firm to hard consistency. What does a phylloid look like if it is low grade? A low grade phylloid usually have these leaf like structures, right? There's a nodular structure with a prominent stromal proliferation. So phylloids has a stromal proliferation. That means your glands are normal. They might have a leaf-like architecture, called as periductal stromal tumors. This is important to know that phylloids tumor is also called as a periductal stromal tumor. Okay. And again, if it is a high-grade phylloid, it will have hemorrhage, necrosis, and mitosis, and atypia, and other components like squamous metaplasia or chondrous metaplasia. Phylloids tumor is associated with its histologic grade. So if it is benign or borderline or malignant, so naturally as malignant as we go, the prognosis gets worsened. But to differentiate between benign and borderline or malignant component and mitotic count, that is very important. Less than 5 per 10 high power field in benign, borderline may 5 to 9 per 10 high power field, and in malignant phylloids you can see more than equal to 10 mitosis in per 10 high power field. This is important. Gynecomastia on gross will usually look like a pink white soft rubbery it may be discrete, but usually it is an ill-defined area of induration within a yellow proper fatty breast tissue. And the microscopy, there is variable degree of epithelial hyperplasia in the glands. The ducts are present in a dense hyalinized stroma. The stroma is densely hyalinized and can show some stromal hyperplasia as well. Now, when it comes to carcinoma, I am not discussing a lot of entities. It will become too complicated then. I hope you remember the clinical features of carcinoma. It is usually a solid mass. Consistency can be firm to hard. It can be grey to white in appearance. You can see yellow to white or blackish areas of necrosis, and hemorrhage can also be present. They might be, if it is extensively necrotic, there may be cystic changes as well. And fibrotic areas can also be seen. Modified Nottingham-Bloom-Richardson grading, which is given on the basis of tubule formation, nucleus size, and mitotic count. Now look at this picture. Apart from the gross, this picture is also showing you tubule formation. Now this section was taken from the tumor obviously, and maximum area of this tumor is showing tubule formation. You can say that more than 75% of the area, so that's why the Bloom-Richardson score will be 3 here for tubule formation. In the next picture we have nuclear grade and mitotic count. If you look at the first picture, there is some variation in size of the cells, but mostly the cells are uniform, right? And there is one mitosis seen as well. So this is probably nuclear grade 2. And this below picture, the cells have different shapes and sizes, and they are proper prominent macronuclei. Somewhere 2 to 3 nuclei are also present, and a lot of mitosis are also seen. And this third picture, the mitotic count labeled 1, we see a lot of flower shaped mitosis. I hope you can appreciate them, and on the basis of this we can divide the breast carcinoma into well differentiated, moderately differentiated, or poorly differentiated, which would be a high grade carcinoma. Now coming to next entity, which is your infiltrating lobular carcinoma. It has very many variants, but we are just discussing the classical variants. The classical variant doesn't have the solid pattern or the alveolar pattern or the pleomorphic or the glandular pattern, which are other types of subtypes. This is your classic pattern, which is the one we call it the Indian file pattern. So if you can see the cells, they are single, and somewhere 2 to 3 cells are arranged in a line, and they're separated by the stroma. So this is your infiltrating lobular carcinoma showing Indian file pattern. So that was all about the breast entities as well. I hope you understood this well enough, and I wanted to make this a very simplified video. Thank you for watching. Bye.